Thank you so much for this opportunity. I'm really honored to be able to participate in this prestigious conference, and thank you for the introduction. So my name is Mia Karam. I am a PhD candidate in the biomedical engineering program at the American University of Beirut in Lebanon. I work with Professors Rami Mhanna and Fayad Jaffa, and today I will be presenting our work entitled Novel Connective Tissue Growth Factor Loaded Alginate and Alginate Sulfate Polycaprolactone Nanoparticles with Promising Wound Healing Activities. So I will start with some background information and state the aim of our study. I will then go over some of the methods we use and discuss our results. And then I will finish with a brief conclusion.
Sorry to interrupt. Please be.
Sorry?
Can you please be a little louder?
Okay, yes, sure. Is this better?
Yeah, it's okay, right? You can proceed.
Okay, thank you. We all know that diabetes is a metabolic disorder characterized by hyperglycemia and affecting more than 460 million people worldwide. Up to 25% of all diabetic patients are at risk of developing diabetic foot ulcers within their lifetime. DFUs occur in patients with diabetic complications like peripheral neuropathy and peripheral arterial disease. Non-healing DFUs are the leading cause of hospitalization of diabetic patients, with roughly $40,000 required for each event. Chronic DFUs can progress to gangrenes, and they may require amputations, affecting 11.2 per 1,000 patients per year and heavily burdening the healthcare system with billions of dollars annually. Now, DFUs are not only costly and prevalent complications, but they're also associated with high mortality rates comparable to those of colon cancer, reaching 16.7% at 1 year and 50% at 5 years. The dysregulated wound healing process in DFUs results in wound persistence and is responsible for these high mortality rates. Now, typically, the wound healing process involves 4 overlapping phases that are primarily initiated and mediated by growth factors, which, as we know, they are secreted proteins that can promote cell growth. The first phase is bleeding and hemostasis, or blood coagulation. So it occurs within the first minute upon injury by forming a blood clot or a thrombus to stop the bleeding and inhibit infection by infiltrating microorganisms. During this phase, we also have activation of platelets that secrete growth factors and inflammatory mediators that are important to promote the transition to the second phase, which is inflammation. This phase facilitates infiltration of immune cells like macrophages and neutrophils, which promote the phagocytosis of the cell debris and invading pathogens. They also secrete growth factors and inflammatory molecules that allow migration of skin fibroblasts and skin epithelial cells called keratinocytes that help in the formation of the scab. These growth factors also promote the transition to the third phase, which is proliferation. During this phase, there are several growth factors involved, mainly the epidermal growth factor, vascular endothelial growth factor, insulin-like growth factor 1, and the connective tissue growth factor. So all these growth factors come together to help the fibroblasts proliferate, as well as differentiate towards myofibroblasts that grip at the wound edges and help them by contraction to help the wound close in order to form the granulation tissue. The fibroblasts also synthesize and deposit extracellular matrix proteins like collagen and fibronectin, which also promote the formation of the granulation tissue. We also have VEGF and CTGF that play an important role in promoting angiogenesis, or formation of new blood vessels, that are vital to irrigate the granulation tissue. Now, in the final phase of remodeling, the inflammation, fibrosis, and angiogenesis are all inhibited, and we have collagen cross-linking and maturation. Also, we have the formation of the final fibrotic and non-functional scar tissue. Now, in DFUs, the transition from the inflammation to the proliferation phase fails to occur, leading to a persistent pro-inflammatory phenotype and a delayed and reduced production and accumulation of growth factors that are vital for the proliferation phase. Accordingly, these growth factors that are deficient in DFUs, they are administered exogenously as a replacement therapy to restore the physiological processes and promote wound healing. However, using growth factors alone is limited due to their short half-life, their rapid degradation in vivo, which means they have a very reduced bioavailability. Hence, they have a minimal therapeutic efficacy, and also their continuous administration at high doses is both harmful and costly. Now, growth factors are stabilized in vivo by glycosaminoglycans that can be sulfated like heparin. So heparin can bind to these growth factors and stabilize them and present them to the cells, which helps facilitate important signal transduction pathways. So delivering growth factors along with heparin, for instance, is a viable approach to deliver the growth factor without compromising its stability. But again, using a native heparin in biomedical applications is limited due to heparin's thermal instability, the high cost of extracting native sulfated GAGs, and the difficulty in obtaining homogeneous sulfation patterns. So what is our aim here? We aimed at developing novel double emulsion alginate and alginate sulfate polycaprolactone nanoparticles for the controlled delivery of the heparin binding growth factors, CTGF and IGF-1, to promote accelerated wound healing. Now for the methods, I will start by just introducing alginate. So alginate, it is a natural linear polysaccharide derived from brown seaweed. It is biocompatible and FDA approved for wound healing applications. Alginate can be chemically sulfated and modified to obtain alginate sulfate with various and controlled degrees of sulfation. Now, alginate sulfate mimics heparin, both structurally, as we can see here, but also functionally, because alginate sulfate can bind by electrostatic interactions to heparin binding growth factors with high affinity. Our nanoparticles are double emulsions that are made of three phases. The inner aqueous phase consists of alginate or alginate sulfate, along with the growth factor of choice and polyvinyl alcohol, which is our emulsifier or stabilizer. The oil phase consists of the hydrophobic and biocompatible polymer polycaprolactone or PCl, dissolved in dichloromethane or DCM. Now, PCl forms a shell around the inner aqueous phase, and therefore it protects the entrapped cargo from being released immediately. Also, PCl by nature has a crystalline structure, unlike other polymers typically used in nanoparticles like polylactic-glycolic acid called PLGA, which has an amorphous structure. In other words, PCl degrades at a slower rate than PLGA. So as PCl degrades slowly, it will promote the sustained and controlled release of the inner cargo. The outer aqueous phase consists of PVA and calcium chloride. Calcium chloride is a cross-linking agent. It helps in the formation of junctions between the glucuronate blocks of adjacent alginate or alginate sulfate residues, and therefore it helps in the formation of a more robust gel structure of the nanoparticles. Accordingly, this will help promote more effective immobilization and sustained release of the drugs. So to synthesize our particles, we use the double emulsion solvent evaporation technique. So first, we form the primary emulsion. We add the inner aqueous phase to the oil phase, and we homogenize by ultrasonication at an amplitude of 50% for 5 minutes. Then we add the outer aqueous phase to the primary emulsion in a dropwise manner And again, we homogenized by ultrasonication, but this time for 10 minutes at an amplitude of 65%. Now that we obtained the secondary emulsion, we set it aside for a minimum of 3 hours on a magnetic stirrer to allow removal of the organic solvent by evaporation and promote hardening of the nanoparticles. We then take our solution and we centrifuge it to obtain a palette of nanoparticles that we wash twice with water to remove any residues of PVA or GCM. We then freeze it at -80 degrees and we remove the water by freeze drying to obtain nanoparticles in a solid state, and we can store it at 40 degrees and we have a prolonged shelf life. So what did we find? We synthesized the 0.5% of alginate or alginate sulfate nanoparticles that were loaded with either IGF-1 or CTGF. We conducted the dynamic light scattering technique, or DLS, to study the physicochemical properties of the nanoparticles. So first, we found that the nanoparticles had an average hydrodynamic size between 200 and 243 nanometers. This means that they are in the optimal size range for efficient biodistribution and extended tissue retention time. Also, the polydispersity index, or PDI, was relatively close to 0.1. So this means that the particles have a homogeneous size distribution and that they are monodispersed. The DLS also showed that the particles have a zeta potential, or a surface charge, that is negative. And specifically, it was between -11 and -22.6 millivolts, so it's higher than -10. This means that the nanoparticles have a good colloidal stability and they are not likely to aggregate or sediment. We then performed the scanning electron microscopy to view the nanoparticles. And as we can see from the photos here, we can see that the particles have an overall spherical morphology with a smooth surface structure, and they are indeed in the nano range. Then we performed the enzyme-linked immunosorbent assay, or ELISA, to study the encapsulation efficiency of the drug in the nanoparticles and the drug release rate. So we found that both alginate and alginate sulfate encapsulated more than 99% of the growth factor IGF-1, and with a minimum burst release of about 9% and 8% for alginate and alginate sulfate, respectively. Also, the initial release of IGF-1 within the first 4 hours was relatively 38 and 37% for both nanoparticles. And when the release was performed in vitro for 35 days, we found that alginate and alginate sulfate promoted the slow and sustained release of IGF-1, reaching approximately 85% for alginate and 76% for alginate sulfate at the end of the release study. Then we tested the compatibility of the nanoparticles on 2 types of cells that are mainly involved in wound healing. So the first type is a human keratinocyte cell line, or HACAT, and the second are human skin fibroblasts. We performed the cell activity or cell viability assay that is very well known, the MTT assay, whereby the cells were treated with increasing concentrations of nanoparticles, and the assay was performed at 24, 48, and 72 hours after treatment. So first, when the assay was conducted on the HACAT cells, or the keratinocytes, as we can see from the graphs, both nanoparticles did not exhibit any significant cytotoxic effects on the HACAT cells, meaning that they are biocompatible. Also, when the assay was performed on the human skin fibroblasts, we can see that the percentage of cell activity was consistently higher than 100% at all nanoparticles concentrations and at all time points, again implicating that the alginate and alginate sulfate nanoparticles are not cytotoxic and hence they are biocompatible also on fibroblasts. Finally, we wanted to test the ability of the CTGF-loaded nanoparticles to promote wound healing. So we conducted a scratch assay on HACAT and fibroblast cells in serum-free media to study the ability of the particles to induce wound closure by cell migration, and in serum complete media to see the wound closure by cell migration and cell proliferation. So when the assay was conducted on HACAT cells, we found that the alginate nanoparticles loaded with CTGF were able to induce the most rapid wound closure at 72 hours, reaching approximately 65% in the serum free media, and 100% in serum complete media. Now, when the assay was performed on the human skin fibroblasts, we found that it was the CTGF loaded alginate sulfate nanoparticles that were able to induce the most rapid wound closure, reaching approximately 78% in the serum free media, as we can see in the photo here, and 100% in serum complete media. So overall, what can we say? These double emulsion alginate and alginate sulfate polycaprolactone nanoparticles, they seem promising and novel drug delivery systems that are safe, that were able to promote the controlled delivery of heparin-binding growth factors. They enhance wound healing, and they are versatile by nature, since they can be applied in theory for the entrapment and delivery of any other heparin-binding growth factor for the treatment of various diseases. Thank you so much for attention, and again for giving me this opportunity, and I'll be happy to take your questions.